I think we'll go ahead and start because we've got three excellent presenters and I want to make sure we have plenty of time for them to make their comments. I'm Dave Wanzenreed. I'm the facilitator for the Billings Care Transitions Coalition for those of you that haven't met me. And I want to thank all of you for taking time out of your schedules to join us this morning. We have an excellent program this morning. I was able to secure the time of three individuals, Maya Gravgard with St. Vincent Healthcare, Amy Reddy, and Denise Oliphant with Billings Clinic to help us understand better how each of those hospitals prepare their patients for discharge and then the processes they use to manage post-discharge care. So I drew some lots and Maya's name came out 2 times out of 3. So St. Vincent Healthcare is going to go first. I've asked each of them to try to manage their time so that we can have some time left over during after the presentations for questions and answers. And I'll make sure we have their contact information. I'll share it with all of you. So with that, Maya, I'm going to turn the floor over to you and ask you to make your presentation. Thank you. And you're on mute.
Of course I am. So I am going to share my screen. Can everybody see that?
Yep.
Okay, great. So, we can get that off there. So I am Maya Gravegard. I am a nurse and I have been a nurse for 35 years. But I found my true love in the last several years in care management. So I am the Director of Care Management and Utilization Review for St. Vincent's Healthcare. The utilization review piece is region-wide, so all of Montana, including Holy Rosary and St. James and Butte. Soon I will actually have all of the care management departments in all 3 care sites, really to make the system better as far as working together. And over the course of the 9 months I've been here, I've also inherited the outpatient care coordinators as well. And what that has done is really help emphasize the need for great communication across the continuum. So I will, our continuum of care, really, it just is one great big circle. Inpatient going to a transition of care to outpatient, back to the emergency department. And at any point in time there, we can go from emergency department right back to transition of care or right back to outpatient or inpatient, depending on what the patient need is. And our goals of care for our community are to provide that quality patient care throughout the continuum of care. Make sure our patients have everything they need to be successful. Increase our partnerships with our post-acute associates. Be worthy stewards of our community. Decrease the length of stay in the hospital and decrease readmissions to the hospital. All those are definitely ones that lead into a better patient satisfaction. As we're decreasing that length of stay now that we've seen in the last 4 months, decreasing utilization in the outpatient setting, but increasing patient awareness of resources that are available to them in our community. And just being a part of this group has really facilitated a lot of increased resource awareness for our care managers and passing that along to our patients. And then increasing our patient knowledge of their disease processes. I found over 35 years, if somebody is unaware or not fully aware of what, let's just use congestive heart failure, if they're not fully aware of their disease processes and what's going on, they're going to end up back in the hospital. And each time they come in, of course, their body continues to wear down. So patient education is very important. So starting with the inpatient, what we have here is we have 12 full-time social workers. with a varying degree of interest. Drug and alcohol, we secured a licensed addiction counselor. And she has really been a bright spot to our team, considering 20 to 30% of all admissions are addiction related. So drug and alcohol, mother, newborn, NICU, PICU, the ICU, palliative.
I'm on a Zoom call.
Neuro, ortho, and emergency department. And we have 5 RNs currently, also palliative, cardiac, neuro, and we do have a complex care manager. We also have a care management coordinator that helps with all of those little things that we need throughout our day. I have a care management manager, and then I myself as the care management director. Upon admission, all patients, including outpatients, the observation patients, and inpatients, have an admission screen done by a care manager. And there's 3 highlighted areas in that screen, and it's expected discharge destination, any other risk factors they might have, such as age 75 or greater, and then any social determinants of health. And if they screen positive for any of that, a full assessment and plan of care are completed, and we see those patients no less than 3 times a week, but more often it's daily or several times a day. Although we don't know upon admission, we can only take our best estimate of discharge disposition. We may think when they first come in, oh, they're definitely going to need a skilled nursing level of care. But throughout their admission over the 3 to 4 days that they may be here, we may find that they're doing better and can go home with home health. And we're always going to try and get them to the least restrictive level of care that we possibly can. Nobody wants to go to a skilled nursing facility if they can go home. So that's our goal. And we discuss the estimated date of discharge with our patients and their families and put it on their communication board so they can be more aware and know the things that need to be done throughout their hospital stay, like getting up and moving. Every day that is spent in bed, those patients are losing more and more functionality. So getting them up and out of bed, expected discharge date, having somebody lined up that can come and pick up the patient, and not saying, oh, my family can't get here until Saturday. So, really working with them on the front end. Discharge planning starts from day 1. And our flow is, that ongoing care management. We're dealing with advanced directives, getting durable medical powers of attorney set up, drug and alcohol resources, our housing initiations. We are part of the HIMSS assessment program, which is the homeless assessment. And we can follow our homeless population throughout their stay, and then once they're in the community, and see where they're at as far as being able to get into some housing. We will always set them up with new PCPs. We do family conferences. We do have a pretty rich palliative medicine group, and we'll do palliative conferences. Financial services, community resources. There's so much that we definitely go through. Guardianship. And that one we're finding is taking a very, very long time. And we're looking into what can we do in a hospital situation. And I look to our Billings clinic partners in speeding up the process of guardianship. That has really been a barrier to get people to the next level of care. And then, of course, referrals to post-acute facilities. We have multidisciplinary rounds every day. And those rounds have really changed over the last 6 to 9 months. But the providers are available. A unit nurse is available, the care managers, dietitian, therapies, respiratory, and pharmacy. We're thinking about possibly even adding radiology into the mix. But what we do is we discuss any barriers they may have to discharge. And we're dealing, with people, again, that have addiction issues, homelessness. So all of those things are discussed in those multidisciplinary rounds. We're looking at what that next level of care is probably going to be, and always looking at that estimated date of discharge. These multidisciplinary rounds we found are invaluable to really working with an entire team of what can we do for this patient. On discharge day, we have admit discharge nurses on most units, and they will go over the after visit summary and any additional education that the patient might need. We make sure they have that follow-up primary care provider appointment, any specialty provider appointments. We do have a clothes closet here. So if you're looking to get rid of any clothes, we would love for any donations. Especially shoes and socks tend to be some of the things that people are very much in need of. So we'll give them the clothes that they need. Follow up with outpatient care coordinators, and then meds to beds. We have that availability, but we also do a lot of charity meds, and we can charity meds for a month at a time. And then of course the transportation to destination. Billings has a issue with transportation. We have 2 ambulance services in town that really can work with us to get people to their destination. But we also utilize Lyft. Even our security has offered to get people to that next level of care. So transportation is something that is definitely needed more of in Billings than we currently have. So we move on to just that transition of care, and what that is within 24 to 48 hours of discharge, a care coordinator from the primary care physician's office will be following up with a phone call. And they have a laundry list of questions that they go through, including going over their medications, and making sure that they've gotten their medications. And then they follow up to make sure that there is an appointment, and is there a need to possibly get other people involved in their care. From the emergency department, if they discharge from there, it is one of our clinic RNs that will actually follow up with them within that 24 to 48 hours post-discharge. And we just instituted what's called Well Health, and that is more of a electronic platform, technology platform, where people that do have cell phones with the right technology will get a text and see how they're doing, and if there's anything on there that the patient is not doing as well as they should be, it will constitute a callback from one of our patient access nurses. Outpatient, there are 7 RN care coordinators currently, and we have 2 community health workers. And that's something that I found was completely underutilized, and we definitely have started utilizing them more. This is really a gap closure to, there's nothing better than seeing a patient in their home setting to see exactly what's going on. There certainly are limitations. The 2 community health workers, one is a social worker, one is an LPN. It is not home health by any stretch of the imagination. It is simply going in to the patient's home and seeing what is their living situation, possibly looking in their refrigerator. What type of foods are you eating on a day-to-day basis? Those type of things, and following back up with the RN care coordinators. Post-discharge follow-up appointments, we have really tried to nail that down to just being within 7 days of discharge, more and sooner for those that are even more complex. We have found with COVID that our COVID patients really needed that 3 to 4 day follow-up because there was a lot of readmissions in the beginning of that whole pandemic. So, and then we continue with the care coordinator, putting certain patients on longitudinal care coordination. And those are the really complex medical patients. Our high utilizers, they will do follow-up calls for a period of anywhere from a month to 6 months. And unfortunately, some of them have patients on there that have been on there for about a year. At some time you have to cut the cord. But if we're finding that the patient is really benefiting from that care coordination, that we will keep them on. It is the care coordinators that will refer to the community health workers. And I think at this time, the plan is to add 2 more community health workers and also offer additional education to the patient. And then our emergency department, we have 2 social workers. This is something new for St. Vincent's that I was able to get started, and they will be working 7 days a week really helping begin that care with some of those patients and coordinate that outpatient care coordinator, talking back and forth with them. What can we do for this patient? We will possibly, if at all possible, we will place the patient in a post-acute care facility, depending on insurance and everything, possibly home health and hospice. It's amazing the amount of people that will just bring their loved one in because they just can't do it anymore, and really not knowing what is out there and possible. And getting somebody home on hospice is something that we can definitely do. Patients that come from a post-acute partner, working with them to make sure the patient gets back to the post-acute rather than being admitted. As you know, readmissions are just really tough on the whole healthcare continuum. So working with our partners out there, giving the patients the resources they need to be successful. And we're always working on our resources. Again, this group has really been beneficial to getting some more of those resources. Like Linda Roars, who was here last time, not knowing everything that was truly available at Riverstone has really been helpful for us getting patients to the right primary care provider. And then if there is a medical need for admission, beginning that screening process right out of the emergency room. Again, this is something new for us. It is a work in progress. There hasn't been anyone care management wise in our emergency room for over 10 years. So very excited that I have 2 really great social workers that are on board. And some of our areas under construction still is really that sustainable, easy to understand disease-specific education. And the top 3 that come to mind are COPD, CHF, and diabetes. And one of the things that is a pet peeve of mine is when people say, well, they know everything they need to know about COPD. I don't know what more I can do. And well, evidently there's something that's not computing with them. Otherwise, they wouldn't be coming in over and over with exacerbations and with problems. So, that continued education, increase our collaboration from inpatient to outpatient and vice versa. Actually got my inpatient care managers and outpatient care managers together in the same room since the pandemic has, well, it's not over, but lifted a little bit. And what a wonderful group of healthcare professionals, and really start working on that collaboration. The Well Health is, again, just starting. We'll see how that goes. I'm sure we're going to run into some glitches, but anything new is you're always going to have that. We're working on a transition of care summit for this fall, and it will be opened up to the community, and it's really learning the different levels of care. We are finding that providers honestly don't know what a skilled nursing facility can do, what home health can do, what hospice is. So we'd like to get some type of a summit put together for this fall for education purposes, and then just educating for the community. I'd really love to see a group of us get together, put on some different educational opportunities for advanced directives. One of the hardest,
Maya?
Yes.
Maya, excuse me, we're at 20 minutes, so I'm going to ask you to wrap up here.
I am done. I am, and then also.
Okay, I did want to interrupt, but
Nope, I am done.
My apologies. Okay, Billings Clinic. I see Denise is here, and who's going to do the presentation?
This is Amy. I'm going to go ahead and start, and then Denise will finish. And I didn't get slides ready, and I don't, as I listen to Maya, our programs really mirror each other. A few differences. We have a little bit more robust ED department. We have usually 2 social workers during the week and 2 RNs during the week. One of the RNs is really focused on utilization review and getting that process started to make sure they determine whether the patient is inpatient or observation, if they meet criteria to be admitted. Our social service care managers in the ED are looking at also, can the patient go right to an assisted living if that's what placement is needed? Are they eligible for hospice and don't need to be admitted for that? Skilled nursing facilities are harder out of the ED because usually to qualify for a skilled stay, the patient needs a 3 midnight stay. So it's not easy to get a patient admitted right to skilled nursing from the emergency department, but we do look, if they just need true long-term care, sometimes that can be arranged. We have care managers in all of our units. So the cardiac unit, ortho neuro, inpatient medical, inpatient surgical, inpatient cancer care, the ICU, and also PEDS, Family Birth Center, NICU. And we have teams on all of those floors. So most of the floors have 2 social service care managers and then an RN. We do have a couple floors where we have full social service teams as we're recruiting for RNs. It's challenging for us to get RN care managers hired and in place just because there's so much demand for RNs throughout the community. And then we do have outpatient care management. So in all of our primary care clinics, including Cody and Miles City, we have RN care managers. We also have social service care managers. And then for the rest of the clinic, we have a specialty care management team. So those are mostly social service care managers. They're based in cardiology, neurology, same-day care, but can cover, and also ortho. They can cover needs from any of the clinics. A big part of what we do here at Billings Clinic is we have a large percentage of our patients come from outside of Yellowstone County, about 40 to 50%. So we do spend a significant amount of time trying to coordinate with resources out in the region, including the critical access hospitals. When patients are admitted onto the units, we also do a needs screening, looking at social determinants and what the patient's going to need, what kind of placement they'll need at discharge, what their estimated length of stay will be. We also have daily rounds during the week where we look at And those are multidisciplinary. What does the provider think as far as estimated length of stay? What kind of care is the patient going to need? And what can we set up sooner than later so that we can get that care arranged? We have twice a week, we look at our long length of stay patients. So those are patients that have been here 5 days or greater, and look at what other things do we need to get in place. And sometimes they're just simply not medically ready for discharge, but we have a fair amount of patients who probably are ready for medical discharge or close to medical or medically ready, but struggle with those social determinants and placement. I agree, Maya, guardianship is a huge issue. It seems like we can identify that fairly early, but to me, it feels like the legal system has none of the sense of urgency that medicine has. And so it just takes a long time to get those guardianships in place. So we can end up with patients who end up staying here a really long time when what they need is to be admitted to a long-term care facility for long-term placement. So that's one of our challenges. Also struggle with our homeless population and how to serve them, but then also set them up for success so that they are not frequent flyers or being readmitted in and out of the emergency room. We do have the psych center here at Billings Clinic. The care managers there are under different leadership, so I don't supervise them, but we certainly see the impact of mental health and the challenge in finding resources for those patients when they discharge. Those can be really hard for us to find appropriate placement for. So I think all of the programs that Maya talked about, we either have or are working on. We don't have community health workers right now. We do have patient support specialists in the hospital and with our outpatient team. So our patient support specialists are non-clinical staff who meet with patients and help with scheduling their follow-up appointments before they leave the hospital. So making sure that the appointments are scheduled at a time that's convenient for the patient and family to actually go to the appointment, and so that people aren't leaving and having to try and navigate the appointment desk to get appointments set up. So they do that for patients who follow at Billings Clinic. And then they also work with patients who are from sometimes we'll end up with patients who are Riverstone patients or St. V's patients, or the patients who receive care out in the region or with the VA. So that team also works to get those patients scheduled with the appropriate resources that they utilize out in the community. And so, sometimes we'll end up with truck drivers who have some kind of an accident or a medical emergency, and they really live in Georgia or Florida or New Jersey, but they end up here so they can help arrange that follow-up care. Or we end up with people on vacation, so helping get those scheduled so that they can get followed up. That team on the hospital also does some of our form delivery. So there's certain Medicare forms that have to be delivered to patients, the IMM and the MOON. So that team does that work as well. And then we have outpatient focused patient support specialists. And so what they do is really look at gaps in care for patients. So have they not been in to see their primary care provider in over a year? Are they due for colonoscopy or a mammogram? And then they reach out to patients and try and get those appointments scheduled. We don't have a Well Health type platform yet, but have been looking into that. We really struggle on the outpatient side to identify rising risk patients. And we think that if we can capture those patients as their chronic illnesses are starting to escalate before they're in that top 5% chronically seriously ill, because we know that all of the care management resources that we direct at that top 5% are probably not going to change them from being high risk. Once you get there, you're usually chronically ill until you pass away. But if we could help people as their high blood pressure starts to really climb or their diabetes is out of control, if we could help them turn that around, we think that we could make much more of an impact on our population. So looking into that, but don't have a platform quite yet. So that's really the program that we have here at Billings Clinic, but I wanted Denise to visit with us about a new program that we're working on starting, which is our Transitions of Care program. So Denise, if you wanted to take over.
You bet. I've been in care management for about 16 years and do have experience in inpatient, outpatient, and ED care management, which has been phenomenal in helping to lead a team of fantastic RNs and LPNs on the outpatient side. I supervise 20 RNs and LPNs that are, as Amy said, embedded in primary care, both at the 3 different Billings clinic campuses here in town, downtown, West End, and Heights, as well as in Cody and Miles City. And then we do have the specialty care team that assists those patients that do not have primary care at Billings Clinic or are being seen in specialty care. And that could be folks from Billings or the region. And like Amy said, we do see a lot of folks from the region that do have a lot of care coordination kinds of needs. We spend a lot of time making sure, and we do have an algorithm-based risk stratification program that is built into our electronic medical record. And in addition to that, the information that's gathered from the needs screening that is started in the hospital, the emergency department, or done on an outpatient side helps to really give us the ability to do that secondary assessment to determine as accurately as we can what that risk stratification or where that puts them as far as low, medium, and high risk. We do try to focus our RNs in managing those patients that are at highest risk and helping them to reduce that risk and really develop self-management skills, which would be disease specific, really understanding their signs and symptoms. What are they going to be watching for? And who are the key people that are going to be their resources in that process? And then as much as we can, developing, having it be a relationship-based process to really be an encouragement, but really through identification of what those needs are, addressing those things that we have the ability to, and again, with the purpose or the idea of reducing that risk. In the last couple of months, and this was something that we had hoped to do pre-COVID, but COVID kind of changed the course and the ability for, to move forward in a lot of different kinds of processes. But we are in the process of rolling out a high-risk transition of care team and program. And this involves, and it's an RN care manager who is in the lead on that, who does have home health experience, but this is not a home health program. This is a program where we are identifying those highest risk patients in the hospital. Initially here, our goal is to identify those patients that also don't have a primary care provider that would make it easy for them to receive the highest level of transition of care follow-up. So we do target those patients and unfortunately do have quite a few patients that do not already have a primary care provider. Some of them could be from within Yellowstone County or regionally. We look at those patients that maybe have either declined or are not eligible for post-acute services, like they maybe have a recommendation to go to a skilled nursing facility for some additional rehab or additional services, or they have also maybe declined to receive home health services. And so, as we know, those patients would be particularly at high risk for readmission or for having acute complications that would require them to return. Also looking at those patients that have had a readmission or being aware of them, which we do get daily reports on those, as well as looking at maybe that choose to leave the hospital AMA. So against medical advice, certainly puts them at high risk for readmission and not having all of the resources necessary to be successful at home and to really self-manage in a quality way. So we have moved this RN care manager actually into our inpatient care management setting, where she can readily interface with our inpatient care management teams She is rounding on the hospital units, working with physicians. We also have social services who are available to work with her as well. And we're trying to identify kind of in a couple of different categories, those patients that live in Yellowstone County, primarily that don't have a primary care provider, that are high risk in one of these other categories, that may benefit from a single home visit within 24 hours after discharge. So she has begun doing that. Where we're seeing the greatest needs so far is in folks that really do not have a clear understanding of their medications, folks that do not have a good support system, that folks that need to get connected to community resources. They need to have the tools in hand and the someone to assist them kind of in getting set up so that they can be successful. So we are just starting that program. We also have a nurse practitioner who is going to be added to our team that will also be available to do home visits for patients who are homebound. And that we are going to be utilizing that even for folks that go home, maybe that don't have a primary care provider that can write the orders or assist with home health, that nurse practitioner can then be assisting with that. And then we have a physician partner as well to support that work. Trying to think, what else, Amy? Anyway, we also just are continuing to, even on with our outpatient care management teams that work within the primary care setting, really continuing to evaluate their risk stratification, or doing that risk scoring, trying to identify again those things that we have the ability to support them in to reduce their risk, with the primary goal of self-management, and then continually working on the access needs that patients have, whether it's with primary care or coordinating those specialty services. We are also really ramping up in the area of, with these patients that live regionally, which, as Amy mentioned, are up to 50% of our patients, taking more of a leadership role in connecting them to the community, to the resources within their home communities that can continue to follow them, whether that's in primary care or just in other community resource areas. And also we have RN care managers on that specialty care team who are also then doing follow-up phone calls with those patients and continuing with the care coordination and assisting them with self-management tools and skills as well. So would love if anyone has any questions about that.
Wow, I feel like I've sat down at a table with a large feast of goodies, and I'm gorged here with good information. I want to thank all the three presenters and open it up for questions. I was looking at some of the chat here, and I noticed that there was some discussion about the follow-up within 14 days with a primary care physician. And does anybody want to comment on that any further, Maya or Dr. Temporal? And I see that Mike Coleman having had some comments regarding essentially the same kind of thing about the need for education and personal monitoring to ensure that we prevent rehospitalizations. Any thoughts along those lines, anybody?
This is Mike. I would just like to comment on that, expand on that a little bit. Going in the field of doing some home health. I just noticed, first of all, can you guys hear me okay?
Yes.
Okay. What I've noticed is these people are coming home with their packets of information, and they can readily pull those out and share those with us, because I often ask, well, do you have any exercises or instructions as you're discharged? However, their understanding of that information, I feel is compromised, partly because they just come out of a hospital stay, and we're dealing with a lot of elderly people. and they're just not processing that information or understanding it. And some of them go back to what they were doing, for example, meds or how they're eating or how they're dealing with their COPD, diabetes, etc. And I feel like we need more nursing to be prescribed or referred initially, at least to do some education and continued training. What I'm finding is often these patients will come out with a referral for physical therapy and occupational therapy. We'll go out, and upon our first visit, we're calling the physician's office back and saying, hey, can we get nursing in as well to assist with med management or further education? They're just not processing that in their stay and in the time they're in the hospital, because I think they're bombarded with so much information and they're just not well. And when you look at national averages of use of home health, Montana is underutilized considerably. And I just feel like we could, and of course the other issue is availability of home health. That ends up being an issue too. It'd be great if we get more referrals, but can the community support that and get out there within that 48, 72-hour time frame to be effective?
Mike, this is Maya Graveguard, and I would wholeheartedly agree with all of what you just said. I think that you wrote the 48 to 72 hours is critical. Absolutely. And thanks for, just stating that we're not necessarily getting a lot of nursing referrals. So I will pass that along to the care coordinators. But again, part of the problem is the access and not having the availability. And so, yeah, but thank you.
Can I break in a little bit? My name is Katie Felstead. I'm with Big Sky Senior Services. I am a registered nurse. And if you all aren't familiar with Big Sky Senior Services, we're a nonprofit. And what makes us a little bit more unique for nursing in any case is that we can offer kind of ongoing medical case management, whereas like a home health RN might be tied to like Medicare guidelines and might offer like a 6-week period of time. So yeah, my role specifically does deal with medications and medication management for clients at home, but what it ends up being also is ongoing medical case management. So if you're interested, we welcome any referrals from any source really, but from the hospitals in particular or home health agencies, anybody. So please feel free to contact Big Sky Senior Services. Again, my name is Katie, and I'd be happy to discuss any patients or opportunities with you that you have. Thank you.
Thank you, Katie.
Katie, who do we ask for? If we call, does your program have a name, or is it you yourself?
It's actually Senior Helping Hands. Let's see, Denise Armstrong is the CEO, right? And then Lana Landon is my program manager. But so the phone number is 259-3111. And there is an umbrella organization called Big Sky Senior Services, but the program that I work with in particular is called Senior Helping Hands. And my manager, her name is Lana Landon. So she might be your best access point. And again, that phone number is 259-3111. And one more thing I should say is another thing that's unique to our organization is because we are a nonprofit, we offer a sliding fee scale. So it really is tied to a client's income. We can offer home health care services. I shouldn't say home health care, grocery shopping, that kind of thing, kind of unskilled, for as low as like $3.50 an hour. My services are just like $1 more an hour for our lowest income clients, but it ranges all the way up to, like the $22 an hour for our highest income clients, but we really don't have many of those. So it really does, there's a wide range of payment available hourly, and a lot of our clients can enjoy my services and the services of housekeepers, people who will do showers. Our PCAs will do showers for very low cost to them. And again, it'd be ongoing. It's not tied to Medicare or any kind of like skilled, quote unquote, qualification. It's just an ongoing need. So.
Dr. Temple, I see you have a question or some comments.
Yeah, really more of a comment. I think, you know, I'm very thankful that we have care coordinators, social workers, and all the other part of the team that can reach out to the patient in that first 24, 48, 72 hours. And because there's just so much information overload that a healing patient gets at discharge or in the days before their discharge, that they just can't process and forget that they have. And, you know, we come up with these beautiful discharge education packets. We talk about med reconciliation. We do all these different things, but then it either doesn't get looked at, it gets forgotten, or like Mike said, you know, they go back to what they were doing rather than recognizing that maybe there were some changes done. And that high touch of connecting with them in that first, you know, as soon as we can from discharge can make all the difference in the world. And as much as hospitals are 24/7 operations, a lot of times our care management and our outpatient follow-up is 5 days a week. And so, you know, the scary situation is that Friday discharge who, you know, doesn't get called until maybe Tuesday because, you know, for whatever reason, and you don't know what's happening to them in those 3 days, and they end up coming back to the ER for something. And, you know, having that access to all these different things is critical. And, you know, our frustration as a PCP is that we've got a lot of people that want to come in, but, you know, I don't have all these appointments. We try to get them in with one of my team providers and they say, no, I don't want to see them. I want to see you. And, you know, so that, and then that 7-day follow-up gets pushed out to 15 or 21 days. And so there's just so many, we need to be able to educate our patients about what they get when they're going home, how to contact somebody, and, you know, understanding that this is all of a team that's helping you with your care rather than just your PCP. Thanks.
This is Danielle with Compassus Home Health. I just also wanted to piggyback off of that. Any case management that are, you know, they're sending patients home with home health or hospice services. We make ourselves available to go and do those in-person patient visits with those patients discharging from the hospital, or even MD office referrals. If they're in the office getting those orders for home health or hospice, we can come in and do those consultations with those patients to let them know kind of what that looks like with that transition home and what to expect. I know with COVID, it's been kind of a little more difficult getting those in-person visits, but we're kind of picking back up on that again. And that just, like I said, it helps with that transition home with those patients, giving them the education and information provided to know what the next steps are and that they're having that help.
Thank you, Danielle. I have a question for the three presenters. How do you know over time, or how do you monitor the quality of the discharge in terms of the issues that are being raised here? I know all of you are really busy, but is there any way you can actually monitor how well your discharge packets work and whether or not they need to be refined? Are there some best practices out there that you can look to help refine those so that we end up with better, more successful outcomes?
I don't know that we've looked at the packets as best practice. They're really structured a lot by our health information systems. So we have some control over changing them, but lots of it is what Cerner has, and then we add to the D part. I was a home health nurse for a long time before I came to care management at Billings Clinic. And I must say that I think that we put a lot of work into those packets and we think that they're meaningful, but for most patients that I saw at home, either they didn't ever look at those packets, and if they did, many of them did not really understand what all of that was. I don't know how helpful packets really are. I think it's much more important that we tie patients to the resources in the community, to educate the families, to know who to reach out to for those ongoing needs. I just don't think those packets are the answer. That's totally my personal opinion. Dr. Temporal might not agree with me.
As far as St. Vincent's is concerned, I was just having a conversation with our CNO yesterday about the quality of materials that are given to patients. And they're given a 20-page packet, and how many patients actually look at it? They don't. I mean, let's be realistic. So it is actually, we're going to be working on what is actually given to the patient when they leave here and their understanding. And then that we're hoping that will carry over into the outpatient setting. And it's just information overload for most of our patients, and they just don't get it. Good question, Dr. Temporal. And, it's something that we're definitely working on.
This is Mike again. I would support that. I think that information is more for our liability issues than anything else, because like you say, there's 20 pages of information that they're not going to process.
No.
But you also have to remember, this is Libby Marcus. I've been a home health nurse years and years and years ago as well, that a lot of times that information is not only just for the elder or the patient themselves, but it could be for their family members. And so I think any amount of information that we can send home, I know it can be very redundant, but if the patient themselves don't absorb it, maybe for some people, they do have family members that are coming in and they can pick up some of those pieces as well. So I think it needs to be a conglomeration of many types of information that we absorb. I certainly wouldn't want to see those packets go away, because like you said, in home health, Mike and Amy, we all utilized some of those portions of packets just so we could pick up where the hospital left off. But I do believe that there's neighbors or there's family members that might pick up and absorb some of that so they can help as well.
Are there other questions or comments? When you discharge, I'm going to ask the three presenters just to weigh in on this. We don't have a lot of time, but how much attention in all of this do you give to cultural differences of the patients, their backgrounds? I know that all of you look at the social determinants of health, but specifically Native American, when they're discharged, is there any additional care or attention given to the family setting that they have in their culture, and how that might affect post-discharge care?
We definitely do at St. Vincent's. We have an entire department that is related to the Native American, and the name of the department is not at the tip of my tongue, but cultural disparities, something to that effect. But we will oftentimes get them involved in certain cases. So yeah, there is definitely that cultural component when we send patients back, say, to Lame Deer or Crow Agency. So we try to put extra effort into their discharges. Good question.
That is really a good question. And at Billings Clinic, we do the same. We are often reaching out to those, to the clinics or to other resources within those home communities to try to bridge some of the gaps, because unfortunately there are gaps in care for those folks, and on the reservations there aren't as many services So there are always opportunities to continue to to bridge the gaps in care, but it has to be driven. All of the resource, everything that we do has to be patient driven and have that cultural. I mean, you have to just take. I think I probably better just quit here before I go much further. Anyway, it's very important.
And I'm wondering also the difficulties that those that have dementia or Alzheimer's that are discharged into any setting, how that's factored into post-discharge care. What is there? I know that all of you are going to tell me, yes, there's a lot done there, but what specific things can you do to ensure that with all the obstacles that we've just talked about for those people that don't have dementia or Alzheimer's, what additional steps can you take to ensure that their outcomes are improved?
There's a lot of coordination with the families and caregivers that are involved. We also have a dementia care team that's embedded in primary care. And so that team works very effectively with very specific kinds of tools and resources. And we're thankful to have that. And that is a program that we are continuing to grow, but it's of utmost importance. So I think that's a really, really good question that you asked, because that's another area in addition to cultural barriers or concerns or needs that we would have to address as far as that cognitive abilities. But it really, you have to involve other people in that care.
Thank you, Denise. Any other questions? We're approaching 8 o'clock, and I know all of you have busy schedules, and I don't want to prolong this. Is anybody, I want to ask the 3 presenters, if you don't mind, I'm going to share your contact information with all the people that are on the call and with the coalition membership. And if you have anything else you'd like me to send out with the minutes, don't hesitate to send me information. Does anybody else have any thoughts or any other questions they'd like to bring up? It doesn't look like it. So I'm going to thank Maya, Amy, and Denise for 3 excellent presentations. And this whole notion of the amount of information that patients have when they go home and the post-discharge care might be a topic that we can focus on specifically in a future meeting. So with that, unless there's any other questions, I want to thank all of you for joining us today and thank the 3 presenters for 3 excellent presentations. Have a great week. And again, thank you all for everything you do every day to take care of everyone that's in need. Take good care. Have a great week.
Thank you.
Thanks, Dave.
Goodbye.